As we grow up, we go from children to adults to parents, and only when we become parents do we truly understand what our parents did for us. This video has two aims. One is for my community colleagues all across the community, non-medical personnel, basic life support, especially for prevention of childhood injury. For my own daughter, the best thing to do is also to give something for others' children. So who knows, learning about prevention, basic life support may one day be the difference to help your child. Unlike adults, where they often have collapses and arrests, choking in public places where others are there, for children, it's mostly in the home, as said in the APLS, Advanced Paediatric Life Support Manual. And this is why, in the effort of revising for my APLS, decided that it's good to also have a community angle to this. The other angle to this video is for medical colleagues, professionals, that while I learn and revise for my APLS third time, Advanced Paediatric Life Support, wanted to create a video in a form of creative expression as well, so that others can benefit from this work in some or other way. Sudhosi, Budhosi, Niranjanosi, Sansara Maya, Parivarjitosi. Stay clean, stay pure, stay focused, and any ups and downs in lives, any miseries, any accepted changes in this cycle of this world, may you rise above them and rise towards your goal, your final goal, just like the rising sun. A message to and for all of our children who are like the second edition of all of ourselves, and whatever the mistakes we feel in our first edition, we have a chance to improve them in the second edition, in our own children, without placing a competitive burden on them, but for their own personality and their own selves, what is nice. And with that philosophy and the heart and the soul behind the science, let's now move to the science and go into basic life support, prevention, and finally, for those medical colleagues and others, advanced life support, advanced pediatric life support. Thank you. Hope you enjoy this video. Thank you. Basic life support in children. So first, one would approach and check it's safe to approach. Stimulate the child, shouting for help. Airway problems can be the primary cause of arrest in many children, and an attempt to open the airway can be made using the head tilt chin lift maneuver. It may just be that the tongue is obstructing the pharynx, and doing this helps the child breathe again. The hand is placed on the child's forehead and applying pressure to tilt the head back gently, as shown in the diagram. The different anatomy of the infant and the child mean one would go for a neutral position in an infant and a sniffing the morning air position in a child, again shown in these figures. Some children may be having had a trauma, or you may suspect a cervical spine injury of the neck. In this case, it's unsafe to tilt the head backwards, and one would do the jaw thrust maneuver, as seen in this diagram here. One places 2 or 3 fingers under the angle of the mandible bilaterally, lifting the jaw upwards. Again, the diagram here shows. One would look for the success or the failure of the intervention using look, listen, and feel. Looking for chest abdominal movement, listening for breath sounds, and feeling for breath. If normal breathing starts once the airway is opened, the child would be moved into the recovery position shown in this diagram, maintaining an open airway and going for help. If the child does not respond, one would need to give 5 rescue breaths for 10 seconds. Taking a breath in between these. Lowest exhalation by the rescuer should make the victim's chest rise visibly. Too vigorous a breath will cause gastric inflation and increase the chance of regurgitation of stomach contents into the lungs. If the rescuer is unable to cover the mouth and the nose of an infant, may attempt to seal only the infant's nose or mouth with his or her mouth to prevent, and close the infant's lips or pinch the nose to prevent air escape. If the chest does not rise, then the airway is not clear, and the usual cause is failure to apply the correct airway opening techniques. First thing to do will be to readjust the head tilt chin lift position and try again. If this doesn't work, one can try the jaw thrust. The 5 initial breaths are given, and if one notes any gag or cough response to the actions, then they will form part of the assessment of signs of life. Failure of both these maneuvers may suggest a foreign body is causing the obstruction, and one would then go down the choking child algorithm, which we will discuss. Circulation. Once the rescue breaths are given, one would turn attention to the circulation, and one would look for signs of life. So no normal breaths or cough in response to these rescue breaths, and in addition, the absence of a central pulse or signs of life for up to 10 seconds, or an insufficient rate of the pulse, i.e. less than 60 beats per minute in an infant or child, to be compatible with life. And with 10 seconds, if there's no signs of life, which include movement, coughing, normal breathing, one should begin compressions. Now, in adults, one would go for 30 compressions to 2 ventilations. For healthcare professionals and in hospital, one would go for 15 compressions to 2 ventilations in the child. However, it's better to go with the adult algorithm than not to go with anything at all, in case one doesn't remember or is worried to make a mistake. And hence, for lay rescuers, the ALSG has said that if one can't remember or isn't sure, for simplicity, one can just go for 30 compressions to 2 ventilations. If one remembers, 15 to 2 in a child. And the reason is because airway causes of arrest are more common in children. If there's no signs of life and one does these compressions, then the compressions should be at least a third of the depth of the child's, if you have 5 centimeters, or infants, 4 centimeters chest. The exact nature and technique will vary. For infants, one would use a hand encircling technique, where the infant is held with both the rescuer's hands encircling or partially encircling the chest. Thumbs are placed over the lower half of the sternum and compression is carried out. For children, one would place the heel of a hand over the lower half of the sternum, lifting the fingers to ensure that the pressure is not applied over the child's ribs, and with the arms straight, compress the sternum to press it by at least a third of the depth of the chest, or by 5 centimeters. For larger children or smaller rescuers, one may need both hands with the fingers interlocked, and for smaller children, one hand may be enough, compressing at least a third of the depth of the chest. These diagrams, which have come, show this in more detail. The compression rate at all ages would be 100 to 120 per minute. This is because externally it's difficult to give effective compressions faster than this, even though we know the child's heart rate is often faster than this, especially as they get younger into the neonatal age group. Here is a diagram of the recovery position mentioned earlier. So you kneel beside the victim, making sure both the legs are straight. Place the arm nearest to you at right angles to the body, elbow bent, palm up. Bring the forearm across the chest and hold the back of the hand against the victim's cheek nearest to you. With the other hand, grab the far leg just above the knee and pull it up, keeping foot on the ground. And keeping the hand pressed against the cheek, pull on the far leg to roll the victim to you on the side. Adjust the upper leg so that both the hip and the knee are bent at right angles, tilting the head back to make sure the airway remains open. adjusting the hand under the cheek to keep the head tilted and facing downwards to allow liquid materials to drain from the mouth, bearing in mind any C-spine precautions, checking breathing regularly, and if the victim has to be in the recovery position for more than 30 minutes, turning him or her upside down to the opposite side to relieve the pressure on the lower arm. Defibrillators can also be used if available, although cardiac causes of arrest are less common in children. We'll now talk about the choking algorithm. So the vast majority of foreign body airway obstructions occur in preschool children, 3 years and under, and anything can be inhaled, predominantly foodstuffs, and the diagnosis might not be clear-cut, but should be suspected if the onset of respiratory compromise is sudden, associated with coughing, gagging, and stridor. And this also can occur in causes like epiglottitis and croup, but these usually have a prodromal history, whereas it's more sudden with a foreign body often. So here's an algorithm, and the algorithm is divided into if the child has an effective cough or an ineffective cough. If there's an effective cough, you would just encourage coughing, supporting and assessing continuously. With an ineffective cough, it's divided into a conscious and an unconscious child. In a conscious child, you would first give 5 back blows. The diagram here shows an example of back blows, followed by 5 chest or abdominal thrusts. The chest thrusts in the younger children, which is shown here, assessing and repeating. In an unconscious child, one would use airway opening maneuvers as previously discussed, rescue breaths, checking for a foreign body. If one can see it, removing it, otherwise CPR. So, in more detail, abdominal thrusts can cause intra-abdominal injury in infants, and hence a combination of back blows and chest thrusts is used. Diagrams as shown. And children, back blows followed by abdominal thrusts, or the Heimlich maneuver as well. And these diagrams show these in a bit more detail, and we can talk about this repeated up to 5 times. Each time breaths are attempted in a child who is not conscious, one would look, this is on the other side of the algorithm, one would look for a foreign body in the mouth, and if it's visible, remove it, being careful not to push it down further. And the child may still require continued ventilations. If the child does breathe effectively, they will be moved into the recovery position. Cardiac arrest, advanced pediatric life support. 4 cardiac arrest rhythms will be discussed: asystole, pulseless electrical activity, ventricular fibrillation, and pulseless ventricular tachycardia. These can be divided into 2 groups: asystole and PEA, not requiring a shock, non-shockable, and VF and pulseless VT, requiring a shock. Asystole is the most common arrest rhythm in children because the response of the young heart to prolonged severe hypoxia and acidosis is progressive bradycardia and then asystole. The ECG appearance of asystole is almost a straight line with occasional P waves, and one can check this is not caused by an artifact by turning up the gain on the ECG monitor. Pulseless electrical activity is absence of signs of life or a palpable pulse despite the presence on the ECG monitor of recognizable complexes, and it's treated in the same way as asystole and is often a pre-asystolic state. PEA can be due to identifying reversible causes, and in children is most commonly hypovolemia and hypoxia. Trauma can be associated with reversible causes of PEA due to causes such as tension pneumothorax, pericardial tamponade, and also with hypothermic patients and those with electrolyte abnormalities, including hypocalcemia from a calcium channel blocker overdose. In Advanced Paediatric Life Support, the algorithm would be similar to the basic life support algorithm, but then after CPR, one would then move to either the shockable or non-shockable side of the algorithm and consider the 4H's and the 4T's with specific treatments. And the basics is effective ventilations as per BLS and chest compressions again as per BLS. One difference would be one would definitely have access to advanced airway adjuncts to assist with those efforts in BLS, such as bag valve masks and ongoing, if required, intubation for the arrest. The basic life support has been discussed in detail in the previous part, so we'll discuss more about the aspects that differ from basic life support. So there should be a team leader who's organizing and sequencing everything and aware of everything and coordinating and anticipating problems. If asystole or PEA is identified, one will give adrenaline 10 micrograms per kilogram, IV or IO, or 0.1 mils per kilo of a 1 in 10,000 solution. If venous access is not attainable within a minute, intraosseous access should be used. And we can show where intraosseous access can be taken or given as well. As soon as feasible, a patent airway should be ensured, which could include intubation, controlling and protecting the airway, and enabling chest compressions to be given continuously and hence improving coronary perfusion. Cuffed and uncuffed tracheal tubes can be acceptable for infants and children, and again, this is a specialized topic which can be discussed in more detail separately when which one is indicated. The continuous ventilation rate should be 10 to 12 per minute, and during and following the administration of adrenaline, compressions and ventilations should continue uninterrupted, and these form the basis of the resuscitative effort. The only reason to interrupt these is to shock the patient if needed and also to check the rhythm. It may be necessary to briefly interrupt BLS during difficult intubation, but again, this is a specialized area that is discussed in the relevant chapter of the APLS. Chest compressions can be tiring, so the team leader should ensure that the one giving chest compressions is changed continuously in a way that compressions are not interrupted, but at the time of the rhythm check and at the achieved recommended rate of 100 to 120 compressions per minute, compressing to a depth of a third of the chest. Every 2 minutes, one pauses. The compression is to check the rhythm, and if asystole remains, to continue CPR while checking electrolyte position and contacts. If there is an organized rhythm or signs of life, then one would continue post-resuscitation care, increasing ventilation to 12 to 24 per minute. If there are no signs of life and no pulse, to continue the protocol, giving adrenaline at a dose of 10 micrograms per kilo every 4 minutes. One would consider the 4H's and the 4T's, which are the reversible causes of cardiac arrest. Hypoxia, the prime cause in children. Hypovolemia, and there can be significant arrests associated with trauma, anaphylaxis, sepsis. Hyperkalemia, hypocalcemia, and other metabolic abnormalities can be suggested by the underlying condition and presentation, and specific treatments exist for these. For example, 0.3 mils per kilo of 10% calcium gluconate in hyperkalemia, hypocalcemia, and calcium channel blocker overdose. Hypothermia can be associated with drowning incidents requiring a low reading thermometer. Tension pneumothorax and cardiac tamponade especially associated with PEA and found in trauma cases. Toxins, which would have specific antidotes. Thromboembolic phenomena is a final T, and it's rare in children. So, talking a bit more about some of the drugs and some of the specific drugs used. Adrenaline is probably the most commonly drug used in cardiac arrest. Alkalizing agents, the most common being bicarbonate, that should not be given in the same IV line as calcium because precipitation can occur, and bicarbonate inactivates adrenaline and dopamine, and hence the line must be flushed with saline after the adrenaline and dopamine or before the bicarbonate is given. And the routine use of alkalizing agents has not been shown to be of benefit, as bicarbonate increases intracellular carbon dioxide. But if it is used when at all, it should follow assisted ventilation with oxygen and an effective BLS. And it can be considered for the patient in prolonged cardiac arrest only where profound acidosis is likely to adversely affect the action of adrenaline. It can also be recommended in the treatment of patients with hyperkalemia and tricyclic antidepressant overdose. But again, these are specialist areas to be discussed in detail. Atropine doesn't have a place in cardiac arrest and is more used to combat excessive vagal tone in bradycardia in the perfusing patient. Shockable rhythms include ventricular fibrillation and pulseless ventricular tachycardia. These are less common in children, but can occur in sudden collapse in those with hypothermia, tricyclic antidepressants, overdose, and those with pre-existing cardiac disease. The protocol for VF and pulseless VT is to assess the rhythm, and if that rhythm then shows a shockable rhythm, to give 4 joules per kilo of a DC shock, followed by the CPR. One would then give adrenaline after the 3rd DC shock, and then every alternate DC shock at a dose of 10 micrograms per kilo IV or IO. Amiodarone would be given after the 3rd and the 5th DC shock only, at a dose of 5 milligrams per kilogram. Again, just as per the non-shockable side of the algorithm, one would consider the 4 H's and the 4 T's as part of the arrest protocol. So there's not a lot of direct evidence for the best approach to cardiac arrest from VF and VT, and this guidance is based on that developed from adults from the APLS manual. And the guidance is for non-experts in pediatric cardiology. There may be slightly individualized medications and processes used in a pediatric cardiac intensive care unit. In unmonitored children, where basic life support will have been started in response to the collapse, and the identification of VF and pulseless VT occurs when the cardiac monitor is in place, an asynchronous shock of 4 joules per kilo can be given immediately and CPR immediately resumed without reassessing the rhythm or feeling for a pulse. This is important because we know that the longer the pauses between successful defibrillation and the appearance of the rhythm on the monitor, the cessation of the chest compressions will reduce the chance of a successful outcome. And minimal to no harm accrues from unnecessary compressions. The appropriate sized pads should be used, which are 4.5 centimeters for children less than 10 kilos and 8 to 12 centimeters for children over 10 kilos. One pad over the apex in the mid-axillary line, the other immediately below the clavicle, just to the right of the sternum. And for the infant less than a year old, there is some specialized recommendations which can be checked within the APLS manual itself. Amiodarone is a treatment of choice in shock-resistant VF and pulseless VT based on adult cardiac arrest experience. The dose of 5 mg per kilo is used. In specialized cardiology situations, lignocaine can be an alternative at a dose of 1 mg per kilo. Amiodarone is unlikely to be helpful in the setting of VF caused by hypothermia, but can be tried nevertheless. Magnesium, 25 to 50 milligrams per kilo at a maximum of 2 grams, is indicated in children with hypomagnesemia or polymorphic VT or torsades de pointes, regardless of the cause. Capnography, monitoring of end-tidal CO2 can be helpful in managing cardiac arrest, as long as the operator appreciates that the absence of a waveform is more likely to be due to absent or very poor pulmonary perfusion rather than to tube misplacement. The presence of exhaled CO2 during CPR is encouraging evidence of efficacy of the CPR or even return of spontaneous circulation. Adrenaline will decrease and bicarbonate increase the measured carbon dioxide levels, and levels of less than 2 kPa should prompt attention to chest compression adequacy. While 100% oxygen when available remains the recommendation for use during resuscitation process outside the delivery room, once there is a ROSC, this can be detrimental to recovering tissues from hyperoxemia, and pulse oximetry should be used to adjust oxygen requirements to 94 to 98%. Therapeutic hypothermia. Recent data suggests that there is some evidence that post-arrest hypothermia may have beneficial effects on neurological recovery in adults and newborns, and current post-arrest recommendations are to cool to 32 to 34 degrees for at least 24 hours or mild hypothermia, or actively maintain normothermia 36 to 37.5 degrees. Increased core temperature increases metabolic demand by 10 to 13% for each degree centigrade increase in temperature above normal. All children, especially infants, can become hypoglycemic when seriously ill, and blood glucose needs to be checked frequently post-arrest. This is going to conclude for a few minutes for a section upon asthma. We'll look at a few key statements upon asthma from the APLS, a national review of asthma deaths done a few years ago, looking at features of mild, moderate, severe and life-threatening asthma, the management of the same, particular clinical signs to look for, and common pitfalls that one may not consider that were identified in either the National Review of Asthma Deaths, in literature and studies, and my own experience from my own hospital from a root cause analysis that we recently did. And the aim is to try to increase awareness and quality improvement. So on page 57 of the APLS manual, it does mention that clinical signs can correlate poorly with severity of airway obstruction, particularly in young children. This is something we'll come back to towards the end of this section. So the National Review of Asthma Deaths, done a few years ago, saw that 45% of deaths with asthma were avoidable, and there was room for improvement in up to 83% of those who died. 21% had been to A&E with an attack in the last year, and more than half had been on at least 2 occasions. More than 68% had been hospitalized in the month before they died, and it suggested about follow-up and about initial care, a few suggestions. Children fared worse than adults in several respects, and it felt that care fell below the expected standards in almost half of all child deaths. So this is an area where increased teaching and awareness can make a big difference. So what are the features of mild to moderate, severe and life-threatening asthma? So mild to moderate asthma is where one is talking in full sentences, good air entry, SATs over 92%, respiratory rate less than 30 in the over 5 and less than 50 age 2 to 5. The exact numbers can vary depending on which guideline you look at, where you look, but this just to give a rough idea. A heart rate less than 120 in the over 5s and less than 130 in the age 2 to 5s and feeding normally. Acute severe asthma, and this is taken from the 6th edition APLS manual. If the child is too breathless to feed or talk, a respiratory rate over 30 a minute in those over 5, and over 50 a minute in those aged 2 to 5, a pulse rate over 120 in those over 5, and over 130 aged 2 to 5. Life-threatening asthma features include exhaustion, poor respiratory effort, a silent chest, hypotension, a decreased conscious level, and one would always consider in such a presentation, is anaphylaxis a possibility? Because then you need to start thinking about adrenaline and slightly different medications that you would be giving in an emergency. So that should always be in the back of one's mind in the presentation of life-threatening asthma. So the management, so for mild to moderate asthma with SATs more than 92%, one would use an inhaler with a spacer to give a salbutamol. Children under 3 would also need a face mask to help drive through the inhaler of the reliever medication. Where saturations are less than 92%, one would drive through salbutamol, 2.5 milligrams in those under 5 and 5 milligrams in over age 5. And usually this would be at least the acute severe asthma based on the numbers, the SATs. Would give Atrovent alternately with the salbutamol and oxygen at a flow rate of 6 to 8 liters per minute. One would give oral prednisolone 1 milligram per kilogram, or if vomiting, IV hydrocortisone at 4 milligram per kilogram. So the child may well be vomiting, in which case your oral medications won't be absorbed. One would give nebulized Atrovent alternately with the salbutamol, as mentioned previously, nebulized salbutamol, and the dosages over age 2 years, it's 0.25 milligram nebulizers of Atrovent, and under age 2 is 0.125 milligram nebulizers. There is a recent move to also consider magnesium sulfate nebulizers, but as this isn't universal, I haven't included a specific slide upon it in this presentation. Further steps beyond this can include IV magnesium sulfate at 40 mg per kilogram over 20 minutes, IV salbutamol at 15 micrograms per kilogram in those over age 2 and 5 micrograms per kilogram in those under age 2. One would contact pediatric intensive care for further help, anesthetics in your hospital if needed. IV aminophylline is a further dose that can be given, 5 mg per kilogram over 20 minutes, monitoring the ECG, followed by an infusion of 1 milligram per kilogram per hour. And as mentioned, further senior help, specialty help should be there by now, appropriately trained. So clinical signs one should record regularly in any asthma attack, whether it's mild, moderate or severe, would include pulse rate, respiratory rate, including use of accessory muscles, degree of agitation, conscious level, oxygen saturations, and a peak flow. A peak flow is notoriously poorly recorded, but gives a good idea of baseline, of reversibility, and respiratory rate can, surprisingly, sometimes also not be recorded, and that's really important to keep a track of. Going back to what was mentioned in the APLS manual, all of these numbers are really important, but they're not the only things one would look at. Even if the baseline numbers appear to be normal, one would still need to consider certain factors which make it higher risk, including previous ITU or pediatric intensive care unit admissions, a history of anaphylaxis, as those with anaphylaxis and asthma would tend to do a lot worse and one would need to be more cautious. A nocturnal presentation, asthma does get worse nocturnally, and one may want to consider keeping the child in longer or discussing with pediatrics in such a situation. There's no definite one answer in any one case, apart from looking at the raw numbers, but putting different things together. Is the child a recurrent attender? Is this a reattendance? And in the particular root cause analysis I did, that was one thing that was identified, that if a child keeps coming back with the same thing, then one needs to think a bit beyond that as well. And it is difficult, but one needs to just consider that. A history of brittle asthma, the social circumstances, the birth history is important to consider. A premature child, history of special care baby unit, are these higher risk factors, and all of these may add to the clinical picture on top of the baseline numbers and could affect decision making. So this is just a little bit on asthma to conclude, and hope you enjoyed this presentation, both for the community on basic life support and for the hospital on a couple of areas, the Advanced Paediatric Life Support algorithm, and a little bit on asthma as a specific presentation. Although there's hundreds of other presentations, this was just one we picked to focus upon, as it's the subject of a recent quality improvement project that I've undertaken. Thank you.